All right, guys, welcome. Welcome to Erlanger and welcome to the Critical Care Day. I'm really excited that you guys are here, and I think that kind of one thing that I wanted to say kind of towards Jeremy's points are that, you know, we are all very excited to teach you and for you guys to learn, and we don't want you to ever feel like, you know, because I'm new, I'm annoying people by taking too much more time and energy of ours. Like, we love to do this stuff, and so to his point, saying I don't know is just something that's more exciting to us because it's something that we can teach you guys. So I totally agree with that. So let's jump into some material regarding critical care medicine, and we're going to start off with cardiac arrest. So our goal for talking about cardiac arrest, I know you guys, some of you guys had the ACLS already yesterday. So we understand that there's an ACLS card that goes through the algorithms, and knowing those algorithms is a good first step in managing cardiac arrest. But what we want you guys to focus on as you move on in your training is that that's a good basic place to start, but to understand that your role as a physician leader in a cardiac arrest is to be able to dig deeper and pass the algorithm onto what's causing your cardiac arrest and how can I manage this to either get them out of the cardiac arrest or prevent it from happening again. Okay, so I want you guys to be able to recognize, and I'll address what's basic about this and that you have to know on your first day of intern year, and the things that you will develop as you go on during your residency and your goals for knowledge in the future. All right, so mortality for cardiac arrest. So survival to hospital discharge with a good neurologic outcome is not great, 9%, okay? It's a good statistic to know, especially for patients that you're actually counseling in terms of whether they want to be resuscitated or not, depending on their comorbidities and things like that. So something to, a good sort of starting point to know how frequent people actually get discharged from the hospital in cardiac arrest with a good neurologic outcome. And that's what matters, right, is your neurologic outcome. So it seems like an easy thing to understand about cardiac arrest, but it actually can be tricky and confusing when you're in the situation. You don't enter a cardiac arrest algorithm until there is loss of a pulse, okay? And that seems really simple, but I'm telling you that I've seen it confused several times. And it's not whether or not there's a pulse there, it's whether or not you're going through a cardiac arrest algorithm. So the first question to answer is there a pulse? If there's a pulse, then your acute situation that you're dealing with is not a cardiac arrest algorithm. It's going to be something else, okay? So the first thing to address is there a pulse? And if your answer is no, then you're going through your cardiac arrest algorithm. So the two things that matter, and Dr. Greenberg made some of these slides, so I'm going to give him some credit for that, but the two things that matter the most in cardiac arrest and are going to be informing your outcomes are good quality chest compressions and early defibrillation for shockable rhythms. What that means is that for good quality chest compressions, you guys know from yesterday, right? 1.5 to 2 inches depth at 100 beats per minute, okay? What is that? Why is that important? Why is that important? Someone tell me. Good quality chest compressions. Perfusion, right? So we just talked about neurologic outcome. So good quality chest compressions are going to give you perfusion while you're figuring out what's going on, okay? So as you, the physician leader, you are responsible for assuring that there are good quality chest compressions during the cardiac arrest. The second part is early defibrillation for shockable rhythms, which has been shown to get you out of cardiac arrest quicker. So that's important to note that before you do anything, if you have any suspicion that you have a shockable rhythm, you want to defibrillate early. All right, so when you have somebody who's in cardiac arrest, there are 4 main rhythms that you need to be worried about, okay? They go through 2 different pathways. It's either a non-shockable rhythm or a shockable rhythm. If you have somebody in a non-shockable rhythm, you're talking about 2 different rhythms, PEA or asystole. We're going to talk about PEA a little bit more in a little bit, but it's an important, it's an actually tricky rhythm because it can look like a lot of things, and I'll talk about that in a second. The shockable rhythms are really only two rhythms, VTach and VFib. VFib is another tricky one because when you're in the situation, and I've seen this in both the sim lab and in real life in cardiac arrest situations, is that new learners often feel that VFib is really just an artifact on the monitor, but it's not. It's ventricular fibrillation that is a shockable rhythm. It's something that you can get them out of with a defibrillation. And so have a high index of suspicion for VFib because it oftentimes is misinterpreted in a code situation. So you've got two different algorithms to go through if you have somebody who does not have a pulse, a non-shockable and a shockable rhythm. So let's talk a little bit about PEA. So these are 4 different rhythms on a telemetry strip. Okay, the first one, sinus tachycardia, atrial flutter, sinus bradycardia, and atrial fibrillation. In a situation that was not cardiac arrest, some of these rhythms may be shockable. But go back to what I said initially. We don't go through the cardiac arrest algorithm until there's loss of pulse. So if there's no pulse, all of these rhythm strips are PEA arrest, okay? So it doesn't matter that you're in bradycardia or if you're in AFib with RVR. If you don't have a pulse, then you're in PEA. And I've seen that confused a lot in both the simulation situation as well as in real life. So these are the only 4 rhythms that you're dealing with in cardiac arrest, and they're 2 different categories, non-shockable and shockable, okay? All right, so why don't we dive into what you do when you have patients who are in cardiac arrest, okay? And again, this is fresh for you guys, so it's good. So you're getting a little bit of reinforcement of the material. So once you've decided that someone does not have a pulse and you're going through the cardiac arrest algorithm, you're going to decide whether or not they have a shockable rhythm or not. So what are the 2 shockable rhythms again? Tell me. I heard VTach and VFib. Good. So the 2 shockable rhythms. So if you decide that, yes, I have a shockable rhythm, the first thing you're going to do, the first 2 things you're going to do is make sure chest compressions are ongoing and then charge for a shock, okay? And so because those are the 2 things that are going to improve your outcome in a cardiac arrest, okay? As you're doing CPR and checking your pulse every 2 minutes, you can give antiarrhythmic medications as well, which alternate with epinephrine. So your antiarrhythmic medications are going to be amiodarone 300 milligrams on the first dose, amiodarone 150 on the next time you're due for an antiarrhythmic, and then you can also have an option of giving magnesium or lidocaine later on in that algorithm. Now remember that a shockable rhythm can turn into a non-shockable rhythm in the middle of your code. So every time with every pulse check, you actually go back through this algorithm each pulse check. So just because you started off with VTach doesn't mean that on the 2nd or 3rd pulse check you're dealing with VTach, okay? So you go through this algorithm on every single pulse check. So to go over that timeline again, with each pulse check, you're going to decide whether you're going to give a shock, and you're going to decide whether you're going to give an antiarrhythmic or you're going to give epinephrine, and that's for the algorithm for a shockable rhythm. Okay. Now, for a non-shockable rhythm, you're going to still do good quality chest compressions. You're going to give epinephrine for every other round of, in terms of when you're doing pulse checks, you're going to do epinephrine on every other cycle. That's about every 4 minutes, right? And then as you run the code, you're going to address reversible causes. So when you're actually in a code that is, well organized, quiet, when you have somebody who's going through cardiac arrest and going through CPR for 2 minutes, it actually is a really long time where nothing is going on, okay? So that's the time to address reversible causes and to address them out loud so that you have all of the brains in the room helping you with that, okay? There are a couple ways to address reversible causes. in your ACLS, American Heart Association, they talk about H's and T's, okay? So I know you guys know that way of addressing reversible causes. Another way to divide things up is talking about metabolic versus obstructive, where you have things like pulmonary embolism, cardiac tamponade in your obstructive categories of causing PEA or asystolic arrest, and metabolic, so acidosis, hypo or hyperkalemia, glucose issues, things like that. So reversible causes, so this is where you separate yourself from having your basic knowledge of ACLS and your algorithms and whatever's on your American Heart Association ACLS card, to being the physician leader that thinks beyond that algorithm into what things can you do to help get that patient out of their cardiac arrest or to prevent it from happening again, okay? So things that you can do, reversible causes that you can address. So hypovolemia, you can give IV fluids. For hypoglycemia, you can either check a finger stick or go ahead and give an amp of D50. Hypokalemia, you can give bicarb and calcium. I missed acidosis on here, but you can bag a patient for patients who are acidotic, patients who are hypoxic. You can also bag a patient for reversible causes. And then, you know, as your code progresses, if the suspicion is high, other things that you can consider for pneumothorax are chest tubes, pericardiocentesis for cardiac tamponade, or TPA for pulmonary embolism. So these are all things that you need to think about and think about, should I go ahead and just address this issue because I'm not sure if this is happening, or do I have a high enough suspicion to go ahead and try to reverse that situation? Because you have to remember that your patient's dying. So some of these things are okay to do empirically because it may be the thing that changes that rhythm for you, okay? So addressing reversible causes during those 2 minutes where you're just waiting on chest compressions, you've given your drugs, and you have nothing else going on, that's when you talk about what can we reverse in this situation. Okay, so let me address airway management. Sorry, the picture's a little blurry on the big screen. But so airway management in a code is different hospitals do it differently. I would say, though, here, most of us really feel that you can bag a patient during ACLS, during a code, and that is sufficient, okay, for ventilating a patient and oxygenating a patient during a code situation. You can also have an option of doing an LMA, but it's not necessary to intubate. It's difficult when chest compressions are ongoing. If any of you guys have been in a code where somebody will be like, oh, chest compressions while you're trying to get an ET tube in, I just told you that chest compressions are absolutely essential for perfusion. So stopping that for an intubation is irresponsible. And so bagging or an LMA is totally appropriate and fine and expected during a code. Once you've achieved ROSC, if you feel like you still need an advanced airway, you can do it at that time. Okay, so what happens post-cardiac arrest? You've achieved ROSC, and now you're trying to manage this patient to try to prevent them from going back into a cardiac arrest, okay? So post-cardiac arrest, you're going to be trying to address your precipitating pathology. So what I didn't talk about in those reversible causes, because mostly you can't do much about it during a code, that was missing was MI, okay? So post-code, getting things like labs and EKG, doing your point-of-care ultrasound, doing your x-rays, all of those things you want to address and consider them as precipitating causes of your original cardiac arrest, because you may not have figured it out while the patient was in a cardiac arrest, okay? The other things that are involved post-cardiac arrest is you need to address the possible brain injury that occurred during the cardiac arrest. As good quality chest compressions as you try to do, unfortunately, you may still have suffered some brain injury, especially if, say, the code wasn't recognized right away or anything like that. And so preventing further brain injury is really important, and we'll talk about targeted temperature management in a second. You often have some sort of myocardial dysfunction post-cardiac arrest. That's very common. the way that that actually presents, it's sort of like when people talk about a stress-induced cardiomyopathy, where it actually gets better after the stress is relieved or goes away. So same thing with this sort of post-cardiac arrest myocardial dysfunction, where a couple days after the cardiac arrest, that dysfunction may get better, but you can manage that in the interim with pressors. You can also get a vasoplegia, which is sort of similar to, you know, post-cardiac surgery, if any of you guys are familiar with that, or the pathophysiology in septic shock, where you have vasodilatation. And that also can be managed with pressors post-cardiac arrest, but often will happen, and it doesn't necessarily, you should have a high suspicion for maybe a new infection or something like that, but it can also just happen because they're post-cardiac arrest, okay, and just to understand that. Okay, so when you achieve ROSC, there has to be a conversation about targeted temperature management. Whether you choose to do it or not is going to be a discussion with your team, but it should be a conversation. And the whole point of targeted temperature management is that there's some evidence suggesting that you may improve your neurologic outcome when you have patients who get into a targeted temperature post-cardiac arrest. Here, we're doing 36, right, on our protocol. Some places will do a lower temperature. You can do 34, 35, anywhere between there. But the whole point is to target a temperature for 24 hours and to prevent hyperthermia in a couple of days after the cardiac arrest, okay? So that's what's going to help improve your neurologic outcome. Some people may choose not to do it. If you have a patient who actually is doing things post-cardiac arrest, then you may not choose to do targeted temperature management. The whole point of it is make sure you've had a conscientious decision about what you're going to do post-cardiac arrest for targeted temperature. Okay, so that's the quick, short cardiac arrest talk, okay? So I want you guys to understand the things that kind of got out of, what to get out of it that you need to know on day one of starting your rotations, but also what things you need to kind of develop as you move on in your training, okay? So you want to know your algorithm, but you want to be able to expand your mind on the reversible causes and the post-cardiac arrest management as you move on in your training, okay? So the first thing is to know is your rhythm shockable, because early defibrillation matters. Chest compressions and shocks are going to be the things that you focus on the most. Make sure you think about reversible causes. You do not need to intubate during chest compressions. And then consider targeted temperature management post-cardiac arrest. Okay, those are the main things that you need to get out of this cardiac arrest talk. Is there any questions?